the NHS has imposed a huge cost on itself by not having the capital money for this. So at BIVDA, we've been saying that diagnostics should be at the forefront of everything for probably 30 years. Certainly a lot of point of care and community diagnostics could be done because the technology, the science and the products are available. We would also like to see a national director for diagnostics. And NICE works very well for the larger companies because they've got the funds to put it through. You tend to see that it doesn't help smaller companies or SMEs with some of the best technology that you've seen come through. If you don't have the uptake and if you don't have the money available to do something else, then they will launch that elsewhere, and then the UK can be maybe a third or fourth country release. I think the AMR challenge is a lot about investment, a lot about science, a lot about research, but it's also about us changing our behaviour. Actually, if the government would issue capital funds to purchase capital diagnostic equipment for in vitro diagnostics, then not only would that remove the capital, it would also kickstart some of the other things in the life science sector plan.
Voices of Care, the healthcare podcast.
Welcome to Voice of Care. My guest today is Helen Dent, Chief Executive of the British In Vitro Diagnostics Association. Helen, welcome to Voices of Care. Thanks for making the trip to see us today.
Thank you very much. I'm delighted to be here.
It's a seminal year 2025. On the one hand, we're seeing the House of Lords committee saying that if we don't scale up the investment climate for life sciences, we're at a crisis point. And yet on the other, we've had the life sciences plan, the UK trade deal, plenty to think about. It feels like life sciences, it's the best of times and worst of times.
I completely agree with you. There are so many opportunities in life sciences currently, and it's nice to see that the system has actually recognised the importance of life sciences, not just for the health of patients in the public, but also for the economy.
And I think that mission, we'll come on to that in a moment, has been placed at the centre of this government's vision, that nexus between economic growth, the health of the nation, and of course the NHS and life sciences sit within that. Before we dive into that, could you give us a little bit of a background? I think I know what in vitro diagnostics means, but could you bring that to life? Because I think the association's been around for over 30 years and you've been there for a number of years.
Yes, so in vitro means in glass. And essentially, the vast majority of in vitro is blood tests, but it's anything that comes from humans. And our members basically do blood tests either in the laboratory or point of care in the community. A lot of people will be familiar with lateral flow tests during the pandemic,
COVID, yeah.
PCR tests. So a lot of people will be familiar with in vitro diagnostics tests. They may just not know what they were called.
And in terms of the scale, your part, life sciences is a huge sector, 100+ billion turnover, 300,000 people. Medtech is a part of that. And I think you represent the vast majority of the in vitro diagnostic suppliers and manufacturers. Is that right? About 250 organisations?
Yes, so we've got 250 member organisations, and we do actually get new members coming through weekly. We don't have everybody because they've got different reasons for being with other trade associations. But the key thing is that life sciences are able to work really closely together through those trade associations. There are the bioindustry, there's the in vitro, and then there is medtech, because medtech is slightly different to in vitro diagnostics anyway. That's the blood test specifically. We also do animal health. Some of our members are animal health, and that is a key part of the industry that hasn't previously been covered very well. But with AMR, which we might touch on hopefully, with AMR, the animal health area is very much more important.
And just having a look at the bigger landscape very, very briefly, I guess the policy, you must be very encouraged by the budget that took place back in November. We're not going to have a big discussion around all the aspects, but quite a lot in there in terms of putting diagnostics at the forefront and in fact investing in technology as well.
Yeah, so at BIVDA, we've been saying that diagnostics should be at the forefront of everything for probably 30 years since we came into existence. But it really depends on implementation, and it really depends on not just saying the words. Everybody needs to do what they say that they're going to do in the plans and provide the funding to do so as well, because it can't be done with the NHS as it is at the moment.
And you're talking about the blood tests. Can you just bring that to life? I mean, we've all probably been involved in diagnostics. It's actually the gateway to so many clinical pathways. I guess people interact with your members' equipment and work much more than they perhaps realise.
I think people do as well. We're talking about blood tests specifically, but there are all sorts of tests that are done through this technology. I think people would be most familiar with that because people will go to the doctors and they will be sent for phlebotomy. They will have their bloods taken. They will understand phrases like U's and E's and there's so many things that people will actually be using or familiar with. There's an area now as well which has got a lot of promise, but also there's quite a lot of risk associated with it, which is community diagnostics in terms of what people buy over the counter.
Right.
Those are tests that you can buy. It's a CE mark blood test, and you can do it. So that can be thyroid. You may have seen in the news recently about prostate.
Yes.
The challenge with those tests are that there is no medical professional associated with them. So the result relies on an individual doing them correctly, and interpreting the result correctly. That then requires, depending on that result, it then requires somebody to actually do something with that result. So you would then present to the NHS. That link between public doing their own tests and the NHS is not very well defined at the moment. Our industry certainly are quite concerned about that link, because you can't just go into the NHS with your own test, but you can really worry yourself with the result of a test that hasn't been done in a professional setting. So one of our main concerns about the implementation of community diagnostics is ensuring that there is enough support around those tests that can be very useful, can be very helpful. We're all really familiar with our watches and how those run. So obviously we can be familiar with testing as well, but it does need a lot more input and understanding from the public.
As you said, there's quite a lot of promise there. And just staying with that community-based setting, obviously the 10-year health plan, one of the key shifts, of course, is the shift to community. The budget has set aside ambitious plans to grow national neighbourhood health centres, I should say, and a bigger role for community diagnostics. So I guess this now becomes quite an important policy imperative, because your members' work will be even more at the forefront of that journey, which is now shifting leftwards.
Absolutely. I mean, there are two ways to diagnose illness, really. One is clinical and one is through the technology. There's probably many more than that, but essentially for explaining this point. And it is quite difficult to understand to try and get a test into a patient pathway after a diagnosis, because how do you know what's wrong with that person if there hasn't been that diagnosis? However, the NHS isn't failing as it is now in terms of diagnosis. It can improve, of course it can, but there are people who are being diagnosed without that test. So I think one of the most important things, and certainly a piece of work that we're doing in my organisation, is looking at what tests should be the diagnosing test and which tests support a diagnosis that has already occurred. Very detailed. Looking at all the understanding of the pathways, looking how things fit. But it's not a case for us to have diagnostics done where they're not required. It is to have them done at the right time, in the right place, with the right technology. And that can really improve some of the waiting lists. It can really improve the patient experience to be able to do that correctly. And there's some message as well that needs to go into industry as well, which is just because you can doesn't mean to say you should, because the technology is there and there are some things that may not work. But I think a really important piece of work that we need to do as a sector across the life sciences is to establish which tests should be done where and how they should be done.
And that's going to require cross-collaboration, communication from BIVDA together with Association of British Pharmaceutical Industry and other players.
Absolutely, and the system itself, because sometimes it's really obvious what somebody needs and what's wrong with them. And doctors and GPs have been doing this for many, many years with lots of experience. You don't need sometimes a test to confirm. But then often, especially we've all been in that position, let's try this, or shall we try this, or I'm going to test for this, or perhaps this could happen. And then the same with antibiotics, let's try this one first and let's try another one. The testing can actually tell people what is actually wrong, which will then start the pathway and the treatment program much quicker.
So that's really empowering for the patients in terms of co-authoring or being part of that process. Obviously, the patient power is very central to the 10-year health plan. Just want to briefly touch upon the life sciences plan that's came out in July, part of the industrial strategy. You are on record as being highly encouraged by some of the principles. We'll come on to some of the challenges, but that very much puts at the centre the life sciences sector. And I guess it's really needed because the investment over the last few years and the last decade, foreign direct investment into life sciences actually has fallen precipitously.
Absolutely. Our sector has, I think, got the most opportunities that we've seen for a long time. It is encouraging, like you say, it's encouraging to see diagnostics are actually part of it, and they're part of it by design. Previous life science sector plans has had diagnostics in, but it hasn't been very clear where where each part actually relates to the other part. It is a case of fitting in the right place, but also for the system to understand how to interact with that because they haven't previously in the same way. Our sector doesn't work the same way as pharmaceuticals, and it doesn't work the same way as the bio industry. However, all three of the sectors work together because those are different parts of what the patient needs. So I think a lot of work that needs to be done with government and with the system is to understand the specifics and the nuances of each specific industry. That's what this life science plan does actually entail this time. And I think you can see through the language where it talks about medtech and diagnostics and pharmaceuticals differently, that there is a recognition that is there by design. What we need to do now is design how they work together to make sure that those priorities and the ones that are the quickest ones to actually be delivered can be done.
And just looking at the policy landscape or the healthcare landscape briefly before we go into some of the detail, because it's all going to be about the implementation, as you've said. I want to dive into that in a second, because I know that you've been really busy nationally talking about that and interacting. Obviously, if we just focus on the three shifts for a second, we've talked about community. There's prevention, which is really important. And just to highlight for us, actually, diagnostics and the work that your members do supports the shift into community, but also is potentially a really important player in the prevention goals that the government has.
I think so. I do think so, but I go back to what I said a moment ago about those risks. There has to be the supporting infrastructure around the provision of that information to patients and the public in order for that to be useful for prevention. Because the tests themselves perform to a certain level, and that's why they're on the market. So it does what it's supposed to do in the setting that they are supposed to be done, with the evaluation by the professional to read what that result says. When you then start to have people involved who are not clinically trained or they are not aware of it, that is the risk. We've already seen that it doesn't necessarily mean it won't work. We've all used the COVID tests, and we've all used many tests in. And I think if we can make sure that what happens with those results, or the maintenance, or the monitoring, or whatever people may be using them for, they have got access to the necessary medical care, that is where I think we need to focus to make sure the prevention agenda can be actually taking advantage of those opportunities. The technology exists, but does the infrastructure exist around those to look after those public and patients?
Well, let's talk about how that's going to actually happen. Let's talk about the implementation. You've made submissions to the Committee in Science and Technology, and it's really interesting. The first point, the landscape it's clear that diagnostics has a ubiquitous role right across the sector. We all deal with it. To make that more effective may require more funding. It may do. We're in a very constrained environment. The budget is, I think, 2.2, 2.4, depending on which expert you hear, a real-time increase in the NHS budget. So that's much lower than historical standards. The Office of Budget Responsibility says growth is going to be constrained in the next 3 years. So there are guardrails economically. More money is always good, but I think you're on record, BIVDA, saying the first thing we should do is actually use the funding that's existing at the moment more efficiently. Can you explain that? Because I think your case is that the NHS actually doesn't really use its funding as well as it could do, and you could provide more tests with even, well, not less funding, but without the need for extra funding. That sounds like almost too good to be true.
Absolutely. So more funding is absolutely critical. But I and our association looks at it from the point that a technology is actually brought into market or is designed, and then all the way through until the point of use and the point of disposal. So there are different kinds of funding all the way through that. When it actually gets to the point in the NHS where it can be used, there are better ways that the NHS can spend that money, and they could get more diagnostics out of what they're doing if they stop doing things that aren't required. So I refer back to my point about some things are good to be tested for and some things just don't need to be. There's other methods. And then also to look at some of the ways that people just, I suppose they're urban myths for want of a better description. There's in Vitro Diagnostics, we have pathology managed services, for example, and they are funded over a long period of time. So you remember the PFI?
Yeah, of course, Profiles Initiative, of course.
Absolutely. So effectively, what happens when somebody has a long contract and buys a lot of analytic equipment? They have a cost of capital on each year. So you have a compounded cost of capital anywhere between 8.5% and 12%.
So if I'm a hospital, one of your members manufactures a particular piece of kit, you're saying those contracts typically last a number of years with a high amount of interest payment, which the hospital's got to take out of revenue, everyday spending.
Effectively, yes. So that interest payment, they will pay a monthly charge for their service, which makes perfect sense. And the longer you have that service, the cheaper the monthly charge. But then the longer you have that service, the more interest is on top of that.
Yep.
So it's actually, if the government would issue capital funds to purchase capital diagnostic equipment for in vitro diagnostics, then not only would that remove the capital, it would also kickstart some of the other things in the life science sector plan. It's always good for all companies to have cash in the bank from capital purchases. When they've got that, they're an investable asset. So you encourage VC and you encourage investment. When you've got investment and you've got cash in the bank, you will then expand your workforce and then you will grow. Once you grow, you will then contribute more to the economy. And then on top of that, all that will happen is the government will actually spend less on analytical equipment. So we would absolutely push. It's a win-win to stop putting these types of contracts into revenue and to actually just look how much money does this cost to buy the capital, because you also then allow the innovation to come through, because you will then do it on a renewal period of 7 to 10 years, which is a really tidy level for innovation to come through. Because otherwise, if you're tying up a contract for 10, 15, 20, nothing new in that period is going to get into.
So you're locking in potentially outdated technology.
Looking it in on the day that actually gets installed.
Wow. And the potential savings are quite eye-watering. You're saying potentially, even if we take one example, it can be, is it a third or 35%? Potentially, depending on the equipment that we're talking about. The savings could be quite significant for the NHS.
So yes, I will caveat that everybody's analyzers are different costs and they are, different, they've got different technologies. But, you can actually save certainly on an analyzer. If you were to Google, what is the cost of an analyzer? List price 120,000, for example. You can save £70,000 on one analyzer.
That's a huge saving, significant. So shorter contracts, that take into account, and perhaps a different accounting period to allocate capital rather than taking it out of day to day with all these other benefits.
Absolutely, and then the reagents and then the any of the ancillary equipment can be purchased through revenue if it needs to be. It's the actual analytical equipment. That's where the technology is. That's where the investment is. That's where the innovation is. And that's where the cost is. And the NHS has imposed a huge cost on itself by not having the capital money for this.
Right, well, budgets being allocated, that might be something that hopefully the committee is going to take into account and you're going to continue advocating for. If we just step back a little bit, you're on record as saying that, and I think we can all be proud of this country and its research and development, its scientists, etc., that the country is great for product development, but not for growth. Commercialization is a real issue. And one of the barriers, and I think Richard Talbot makes this point, who's obviously from the Association of British Pharmaceutical Industry, is the regulatory hurdle. Because one of the key things you said is any new technology, any new diagnostics technology has to pass an approval process, whether it's the National Institute for Health and Care Excellence or the Medicines and Healthcare Products Regulatory Agency. What are you calling for? Because I think there is in the Life Sciences Plan certainly a desire to make that speedier and more effective and bring products perhaps with less barriers.
Absolutely. So there are a series of nuances with in vitro diagnostics and regulation. In comparison to pharmaceuticals
And
and
medicine.
also in comparison to medtech. It also matters the size of the organization and the kinds of products that you have as well. So I will go on record of saying that MHRA have been extremely responsive and extremely supportive of our members regarding their products. There are some challenges which are absolutely understandable, and this is where we've got the variation. We've got some companies that are university spin-outs, and they don't have that same regulatory challenge. The biggest regulatory challenge they have is understanding it.
Right. It's very complex. Yeah.
Exactly. And then once they've got the necessary assistance through through the NHS support, through also the trade association, they can get a product which is innovative through the regulatory system relatively quickly, and then it's on market.
Right.
Then you have our members, which are the large multinationals or the larger companies, and they've got multiple products in multiple countries, and they are high-end technology as well. That is where the regulations are difficult from the MHRA perspective and from a membership perspective, because you can't just do one process for all of those. And you can't have it different in every country for a global manufacturing organization.
Right.
So our members who are SMEs, of course it could be better. It can always be better, but MHRA listens and MHRA supports that.
So very positive.
Yeah. But they do need to have an understanding or some flexibility to allow for the international, which is extremely important as well for growth, to allow for those international companies not to be restricted and have additional costs on as well. But then there's also targets and programs that MHRA are trying to do to allow the single product or the small product portfolios and the SMEs to get through.
But for the larger members that you have in your association who are producing products and diagnostic tests, etc., around the world, to ensure that people in Britain can benefit from those discoveries and innovation, harmonization, I guess, is an important part of the regulatory process. So that if something is approved somewhere else, it doesn't have to, in a sense, be reapproved as over and over again. Is I think what you're potentially is that what I'm trying to understand?
In each jurisdiction, it shouldn't mean that all of the costs and information associated with getting on market approval needs to be done in every single country.
Yeah, that would just be a duplicated cost.
It's a duplicated cost, absolutely, and the only people that impacts is the patients themselves. And then likewise with, I suppose, with NICE as well. NICE works very well for the larger companies because they've got the funds to put it through. it means something to larger companies when you are comparing, and all of the commercial side and the market and competitiveness. It can actually be really detrimental to an SME or an innovating company, because if you don't get it, then you're no longer an innovation, so you lose your funding because you're not an innovation. And then once you've had assessment, you then still need the uptake, and it changes the position in the capital investment, it changes their position in the market, and they actually have still got no sales. So we tend to see, and this is a little bit anecdotal, but we're doing some work at the moment to actually really provide some evidence to see if that's the case. You tend to see that it doesn't help smaller companies or SMEs with some of the best technology that you've seen come through, because it just doesn't push them further along in the process. NICE, again, they're listening. So we need to make sure that those nuances specifically for IVDs are actually brought through.
So you can create, innovate, scale, and invest is the big thing. And let's do the counter to that, because what's the cost of not doing this properly? I believe, as an example, one of your member organizations, because of some of the regulatory barriers and the effect on profitability and time, made the decision to actually launch their product in another country.
A lot of companies launch it in other countries first. And we want people to launch their product in the UK market. But if you don't have the uptake, then the marketing, it doesn't matter what happens. If you don't have the opportunities because the contracts aren't coming around quick enough, if you don't have the uptake, and if you don't have the money available to do something else, then they will launch that elsewhere. And then the UK can be maybe a third or fourth country release.
Okay, a lot at stake there. So we've looked at the idea of funding, better use of capital payments, regulatory framework, perhaps to be nuanced for larger and SMEs. One final point I want to do is, once that's all done, of course, the product has to go into the marketplace. It has to be subject to the contractual process. And we come to the procurement, the world of procurement. I know you know this really, really well. I think, I hate to remind you, over 20 years ago, the NHS purchasing, PASA, as we all remember it. So this is I think you have 2 master's degrees in it. So this could be a very big topic, but bringing it into reality, procurement is a really important step so that the contracts are actually commercially not just viable, but actually encouraging and incentivizing.
Yeah, so procurement frustrates me because it's been overcomplicated. And it's been overcomplicated because the values associated with it are so high.
Right.
Essentially, if you were to strip back all of the requirements for procurement, you need to get the best technology that is most appropriate for your patient demographic to them as quickly as possible for the right amount of time.
Right.
It is as simple as that. And it doesn't even matter if you complicate it by having every test that exists in the same contract. What matters is the ability to continue getting those new products through the system at a fair and equitable access to market. We understand, and I think everybody would understand, you don't want to be doing a new contract that big every 2 or 3 years.
Sure.
But then also, people need to understand that you don't want to be doing a contract that big once every 15 years as well, because you're not it's like moving the house. If you don't empty the top end of the market, you're never going to get people on the bottom end. And that's what needs to consistently happen. I also think that when you have got government-funded innovations, so it's been through Innovate UK, it's been through NIHR, it's been through all of those programs, and it's actually ready for market, there shouldn't be a question whether somebody purchases it or not. It's already been decided if it's innovative because it's had millions of government money to get it to where it is. It should be a case similar to how it works with pharmacy. It should be a case of, right, this is ready for market, go for it.
Right.
The challenge that we've got is we don't have the same funding structures there. And quite often, even if the extra funding was there, these contracts are long term. So if it's replacing either a similar product
Yep.
or the diagnosis for something else, then you can't get rid of that product either, because you're contracted to that until the end of that contract period. So there needs to be something. They talk about frictionless procurement in the life science sector plan. There needs to be a way of just buying innovations. Nobody, when it comes to, and again, there's quite a lot of regulation behind this as well, but if you've got the first to market for medtech and definitely for diagnostics, you will have the next set come through quite quickly. So if you just buy the first one that comes out because it's got all of that innovation money, if you do that, then it does its own competition. It does its own competitive environment by being available for the next ones that are coming through. Once it stabilizes, you've got several different products on the market. Everybody's got the opportunity and the contracts can roll. It seems to be that in terms of fairness or competition, it trips itself up. And I don't think there's any need for it. And I'm hoping that the life science sector plan, where it talks about frictionless procurement, is going to look and say, now that there's got the new procurement regulations, have we actually got an opportunity to do something differently? I think we can. You mentioned my master's. It's about working out whether you can do things you're not supposed to do. And whether that's really the truth, whether you aren't supposed to do it, or whether it's a misinterpretation of something you can do. And I think the system needs to be looked at. The infrastructure and the system needs to be looked at, because I think that's a key way to get life sciences progressed.
And I guess there's also talk, you talk about frictionless procurement to make this, again, it's the ultimate goal is to attract investment at scale for better patient outcomes. There's talk of procurement innovation champions across departments. So probably, I'd love you to come back next year and tell us if that's actually worked. But this is a key part of your advocacy to make this a commercial environment for people to thrive.
It is, absolutely. But it's also part of our advocacy not to waste time, effort and money if it's not going to be effective. If those procurement champions aren't suitably senior enough, if they aren't paid what they should be paid, and if they aren't able to invest time into doing something and bring those innovations through, all that it will add is another layer of bureaucracy, which takes the money away from the investment, which takes it away from the patient. We would also like to see a national director for diagnostics. But that same thing applies. Is it a person who needs to manage diagnostics for the whole country, or is it a way to interact all of the decision makers into a position so they are all on the same page and they act as though they are a directory for diagnostics? It needs to be looked at in detail to see what the best way is, because you do not want another layer of bureaucracy.
That's a high on your agenda, I guess, over the next few months. Two final points. I want to look ahead a little bit, but looking right now, we've talked about, obviously, the regulatory framework in terms of new diagnostics, new technology, new medicines. But one of the things I think you submitted was the idea that actually one of the biggest barriers is the adoption of existing diagnostic technology that your members already have that can solve a lot of problems. And I think one of the questions is, should we use diagnostic tests, in vitro testing, imaging? So this is about, I guess, communicating the value still, because that's quite interesting to say there's already exists a range of products that could make such a big difference.
There is. I won't list them and probably can't list them all, but where there have been products over the last 10 years, so I would say it's always been a challenge in the NHS. I don't think anybody's been saying anything different for a while, because it's difficult to change. It's difficult to have the necessary understanding of what products are coming through, all of those things. But since the laboratories consolidated 10 years ago, it has been a challenge to get that through. And I would say most diagnostics hasn't had the uptake that it could really have benefited from. But there is some technology that, if it was used today, could address some of the immediate challenges. And I think it would be very useful to look at those. Again, that's part of the work that we're doing, to to just say, pick this up, scale up, not go back in time, but what would have happened if this had scaled up at the point of coming to market, and look at how to do some of those things. Certainly a lot of point of care and community diagnostics could be done because the technology, the science and the products are available. It's the pathway and it's the processes around it that need the work doing to it.
Yeah, and this buy-in from a policy perspective. I think Baroness Meron has spoken very positively about point of care diagnostic. One final thing, just a bit of a crystal ball. There's so many things, of course, where diagnostics, you've explained so well, feature in the clinical pathway. But one of the key areas of work is that one of the big threats to the health system, not just here but globally, is obviously the rise of antimicrobial resistance. And the work that you potentially can do to help with that. I think the World Health Organization said it's one of the top 10 challenges to public health. This goes back to over-testing and where your members' work can make a huge difference.
It actually goes back to overprescription of antibiotics, because there are obviously everybody knows how vital and important antibiotics are. And when clinicians are faced with a situation or an emergency situation, you can completely understand why a prescription has been given. Yeah. You have the social norms from when they came in, in the 50s and 60s, when it became useful. I don't know if you've ever watched like Heartbeats or the hospital is like, oh, have a prescription. People are used to that. However, the drugs are becoming ineffective. There hasn't been a new antibiotic for quite some time. And if these superbugs, as people would probably be more familiar with, if they continue to make the drugs and make the pharmaceuticals less effective, then there's going to be no treatment for those. So we're saying you can test, find out if it's bacterial or a virus. Some technology does actually tell you which antibiotic it should be.
Right. Okay.
So there are those options. I don't think anybody is ever saying, when you're faced with a young child who's come in who might have sepsis or meningitis, go for it. That's no problem. What it is the people who know how to go to the system. You've got a little bit of a chest infection. You've actually got a cold. You might have a virus. COVID, prime example. You do not need an antibiotic. And you also need to give your clinicians plenty of time not to be forced into giving that to you, because they've only got a limited amount of time as well. I think the AMR challenge is a lot about investment, a lot about science, a lot about research, but it's also about us changing our behaviour, because we do not need an antibiotic for most of the things that we have.
Oh, that's a big challenge. I mean, I think the World Health Organization estimated for 2019 numbers, nearly 5 million deaths around the world from these superbugs. So this is a huge issue everywhere. Again, one final point on crystal ball. 10-year health plan has put a lot of weight on the big bets, AI, genomics. I guess that's exciting from your members' point of view. The 3-year midterm planning for the NHS is out, and diagnostics is going to play a really big role, cancer and meeting constitutional standards.
Yeah, I mean, you won't hear me say that diagnostics is not central to everything. It is essential. They are central to everything. The two plans work together very closely. Based on what I've said previously about, about the ability of industry to get innovations into market, and also some of the things that haven't had the scale up and take up that's there. I think there are two separate levels. The first 5 years of the 10-year plan is use what is available, look at what is available, start to enable technologies to come through. The second, and that will be the first 5 years of the life science sector plan, which is where diagnostics will focus on the new processes and frictionless procurement and NICE and all of those things in there in the 33 priorities. And then once the first 5 years of the 10-year plan is done, that is when diagnostics are going to absolutely be ready to do the second part of it with the new technology that has had the 5 years to come through. It's had the support of the life science sector plan, hopefully had the support of everything that has been talked about in the life science sector plan. And that is where we will start to see the genomics coming through, the multi-omics coming through. The things that exist that currently don't have a bucket to call them yet, Those will start to come through if we can release through the life science sector plan all of those opportunities. If we don't do that and we don't get some of the older technology onto the market to address some of those challenges in the 10-year plan now, then we are actually only going to be further down the line where we are now with lost opportunities. I'm not saying it won't work, and I'm not saying it won't be better, because I'm absolutely convinced that both plans will enable that to be better. I'm just saying it will be more of a lost opportunity, more waste, and a loss for the patients if we don't look at how those two plans can work together with industry in order to get this technology into the market.
So partnerships across all policymakers, providers, and then I guess that elixir of economic growth might actually be realised.
I do think so. I think the NHS and the government needs to look at industry as the third part of what everybody is familiar with sustainability. You have the environmental impacts, you have the financial impacts, and you also have industry, because industry are key. If you don't invest in your industry, you do not have that third part of sustainability. And if you don't have that third part of sustainability, by its very definition, you are not sustainable. So you won't be able to grow. They need to realise that they need to buy off their companies. They need to allow their companies to make profit. They need to allow their companies to do business which will enable the growth factors. They need to make a bit of profit. They need to grow. They need to not be just keeping their heads above water. They need to be able to grow, and they can't do that if the NHS doesn't buy from them.
On that clarion call, Helen Dent, thank you very much for your candour and for shedding some light on this part of the life sciences sector.
Thank you.
My pleasure. If you've enjoyed this episode of Voice of Care, please like, follow, or subscribe wherever you receive your podcasts. And if you want to learn more about how we're turning the dial on the health and social care and life sciences debate, please visit the website at the bottom of the page. In the meantime, I'm Suhail Mirza. Thank you very much for joining us on this episode, and I look forward to seeing you on the next one.